Is that
okay? Yeah, so we'll have to struggle a bit with communication, but what I want to do is take you through a little introduction to the global burden of disease, highlight a number of issues where we have had help from philosophers and ethicists in the past to think through issues, and maybe raise a few more things where a bit of help would be useful. And do interrupt me whenever you want. We can divert as much as you like. It has to be useful for you. Okay.
He's done this before.
But actually what I want to do is start showing you some results before we go into anything about methods. So let me shift this one here. So this is what burden of disease is about, that we can show the world what's the distribution of deaths, non-fatal outcomes, risk factors, and how can we make use of this for policy decisions on resource allocation. So this is a typical way in which we show our figures, where the size of the box is the total number of deaths in this case here, and everything nicely stacks up to 100%. And that allows us the magic of telling the world that ischemic heart disease is 15.66% of total deaths in the world, or pneumonia here is 4.74% of total deaths. Now that is a lot, that is very helpful in communicating results, because when we start shifting to DALYS, and you can see it's now shifting in front of your eyes, most people have not much of an idea of what a DALY is. DALY is just a composite indicator that combines deaths and non-fatal outcomes disability into one indicator, but there's no intuitive feel that people have for so many gazillions of DALYs that are being lost. Whereas if we say of the total burden of disease, pneumonia is responsible for 4.5%, HIV for 2.7%, as opposed to road injuries of 2.9%, that's a lot easier to communicate. And I'll get back to this magic of being able to stack up everything to 100%, because there are also drawbacks of being able to do that. So if I go back to deaths, and does the screen move quickly on your end as well?
Yeah.
Okay, good. Because sometimes Skype has a bit of a delay. So if I go back in time to 1990, you can see that there were more of these orangey-reddy causes, and they're all the poverty-related diseases. This is pneumonia, diarrhea, HIV-TB, malaria, malnutrition, neonatal conditions. And so you can see over time we've seen a shift away from deaths at those ages. But more importantly for us, because we think a death in a young person is a greater health loss than a death in an older person, we translate deaths into years of life lost. And then you can see that all these kiddie deaths add up to a lot more years of life lost than adult deaths here among the blue non-communicable diseases. Whereas injuries are somewhere in between, because a lot of injuries affect young adults. But over time, you can see that the picture has changed a lot. A move away from these childhood poverty-related diseases towards non-communicable deaths. And that's an important bit of information for policymakers, because it indicates how health policy has been tracking over time, and which causes have seen greater declines than other causes, and which are the causes that haven't seen any declines or have gone up. And if we look here, if we then shift to the pattern of disability, then you see a totally different picture, dominated by non-communicable diseases, much less so for the poverty-related diseases, but one that comes up that doesn't cause that many deaths is iron deficiency anemia as a big contributor to disability. But look at all these causes that dominate the disability from non-communicable disease. They're all conditions where there is either no mortality at all or it is very little. Neck pain, back pain, depression, hearing loss, migraine, asthma. Diabetes does have deaths, but considerable contribution to disability. Whereas you can't even see the labels anymore. Cardiovascular disease and cancers have very little relative contribution to disability because they're largely conditions that kill, and when there's disability, it tends to be more limited in duration or in scope. And if you look at the pattern over time, unlike what we saw with deaths and years of life lost, YLLs, the pattern hasn't changed that much. So the shifts in disability are much smaller than the shifts in mortality, and that means that we are giving people a longer lifespan, but because we're less good at preventing or treating the major causes of disability, it means that relative to mortality, disability is becoming a bigger contributor to the overall burden. As I said, interrupt me when you want. I'll go back to a bit of background now, if you don't mind.
Okay.
So, we define the global burden of disease as a systematic scientific effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors, and all of this in great detail by age, by sex, by geographies, and specific points in time. We explicitly focus on measuring health loss as opposed to general welfare loss. And we measure it in populations in comparison to a reference or a normative goal for a population living in full health until a ripe old age. So we set a standard and then we calculate our DALYS against that standard. And we use the same standard everywhere in the world, and that is from an egalitarian principle that we think everyone in the world, every population in the world should be able to aspire to the best health outcomes possible. I've already mentioned some of the terminology. So deaths we translate into years of life lost, and the acronym YLL, and it's simply calculated as by multiplying a death at age X with the standard life expectancy at that particular age of death. Years lived with disability in any age, sex category for a cause equals the prevalence of that condition times a severity weight, which we call disability weight for that condition. And then DALYS are simply the addition of the years of life lost and the years lived with disability. Just as a clarification, because we have a lot of misunderstanding about this, in GBD, the term disability refers to any short-term or long-term health loss. So it includes a couple of days of common cold that gives you a relatively small amount of disability. So this work was started in the early 90s, commissioned by the World Bank, and later WHO joined in, and first results were published in 93, then a few doorstopper big volumes that came out in 96, and at the time estimates were made for 8 regions, 107 diseases and 10 risk factors. And estimates were pitched at 1990, and some, well, you could say heroic projections were done to make estimates for 2020. Then there have been a number of subsequent efforts, and a lot of the work was done in the early part of the 2000s at WHO, when there was a large complement of staff working on burden, but also cost effectiveness and health sector performance. And the initial global burden of disease study also spawned a lot of national burden of disease studies that have been conducted and published in, well, it says here 37 countries. It's probably more than that by now. So the big stories of the early GBD efforts were, it was for the first time that a comparable measurement was made of conditions that result in death and those that do not. And by using a metric that combines fatal and non-fatal conditions, it highlighted a whole number of diseases that never got much attention. Mental health, such as major depression, but also musculoskeletal conditions, sense organ conditions, that all of a sudden got a position in the overall scheme of health problems in the world. It also demonstrated that non-communicable diseases, also in developing countries, played an important role, and also highlighted the role of injuries among all the diseases that lead to death and disability. So the problem was that when we had an opportunity to revisit what we had done in the past, we realized that the effect of the past efforts had been limited by the fact that all estimates were made at regional level. And in most countries, decision makers, they don't really care about regions. They care about their country. Or actually, what we find is that most policymakers, they don't care about national estimates. They care about subnational estimates at the state level or at some local level. So we realized that we really needed to work on country level estimates. Another issue is that over time, a number of decisions were made between different versions of the global burden of disease and between national studies that made results no longer truly comparable, and therefore making it difficult to look at those trends over time. There were also a number of important conditions that weren't included, and importantly also we said, well, we make all these estimates, and some of these estimates are based on rather little data that we have available, and that means that some estimates we believe in a lot more than we do with other estimates, and we should systematically carry forward all the uncertainty in all our estimates. So that's was started for the Global Burden of Disease 2010 study in 2007, and it was completed in 2012. And we made estimates for all the major diseases, 187 countries, and we did the whole time series using the same methods to ensure comparability between 1990 and 2010. There were 67 risk factors or clusters of risk factors included. After we completed that study, we said, well, this pattern of interrupted big efforts where for 3, 4, 5 years you throw everything at it and try to make the best estimates possible is a rather inefficient way of doing it. And the demand for this sort of information is growing, and therefore a much more efficient way is to continue to update the global burden of disease, and that's what we're doing under, in the current scheme where we are about to publish GBD 2013, and we'll do annual updates from year to year where we redo the whole time series so that we continue to have comparable data from 1990 onwards until 1 year prior to when we're publishing. So 2013 results come out in 2014 and 2014 results come out in 2015. That allows us to rapidly incorporate new evidence. I'm seeing I'm seeing something in front of my screen. Latch on to new things that are available that could have a big impact on decision making. We can also pick up on methodological innovations and incorporate that into our results, but it does mean that when we do that, we redo the whole time series, and actually every result will change as a consequence. So I won't go into too much detail here, just that we have a whole lot of experts that we collaborate with, and we're trying to fill in all the white gaps. I recently was in Nepal and am enlisting experts from that country as well. Let me go on to some of the key debates, because I think that's probably what you're most interested in. So, from the early study on, a lot of the debate was on two decisions that were built into the calculation. That was discounting and age weighting. And there were many calls to drop these for a range of reasons. Probably the more important one, that it was pretty hard to explain to users of the data. There's also debate on the advantages of making the non-fatal estimates based on new cases or existing cases. There's an important issue about comorbidity, where an individual can have multiple conditions, and in the soon-to-come-out paper on our non-fatal estimates for 2013, we actually draw up population pyramids that indicate what proportion of the population at each age suffers from 0, 1, 2, 3, 4, and up to, I think there's some poor sods who have 20-plus conditions that they suffer from. Now, the way we make our estimates is that we award disability for each individual condition. But that means that in any individual, if you stack up in an additive model all the disability, it could make that person a whole lot more disabled than dead. And some people truly feel that way, but it probably, for pragmatic reasons, is better to avoid that, because it's if that occurs, it would be pretty rare, and we'd rather stay within plausible limits of how we make our estimates. And so we do an extensive simulation of the world's population to determine who has multiple conditions at the same time, and then rather than assuming that the disability is additive, we make the disability multiplicative, and that constrains our estimates between 0 and 1. There's not a lot of empirical evidence to support this, but there is a bit, and that seems to indicate that it's not too bad if you do a multiplicative model. Then the fourth one was that in previous global burden of disease, we had a choice of a normative standard life table where we decided to use one that had 80 years of life expectancy at birth in males and 82 and a half in females. That was considered out of date, and I'll show you in a while what instead we have chosen to do, because clearly this is a choice, not based on evidence. So in 2011, we convened a meeting with a group of philosophers, ethicists, and economists to discuss all these different arguments. The conclusions from that meeting and our willingness to interact with philosophers has increased rather steeply. I remember the first time I was in a room with philosophers and ethicists, I thought we were speaking a different language, but over time I've learned to appreciate the contributions, and it actually has helped us think through some of these more difficult decisions in a lot more clarity than we had done before. So the fact that we explicitly choose to measure health loss as opposed to welfare loss, and that it is possible to measure health loss as distinct from welfare loss, was supported as a feasible thing to do. There was consensus that we shouldn't be discounting, as it was unjustified for assessing the magnitude of health loss in a particular population at a particular time, and particularly that it gives less focus on health loss that may occur into the future and may be affecting future generations, and that there's no good reason to say that therefore it is a lesser amount of health loss. There's a recommendation not to use the age weighting, and I think there are some philosophical arguments around that, but there are also computational arguments against the age weighting. One being that if you translate deaths into years of life lost, that is an implicit age weighting of mortality. If you then on top of that put another age weighting function that was derived from using different arguments, the combination of the two is no longer supported by either of the arguments. And there was also an endorsement of moving from an incidence perspective to a prevalence perspective, and to do the comorbidity corrections. Just to show you the new reference life table, we said we need to, now that we are revisiting all these assumptions, we probably should update this standard life expectancy, and we decided to create a synthetic life table where we looked at the lowest observed death rates in each 5-year age group in 2010 in countries with populations greater than 5 million. And that ended up, when you cobble all those together in a life table, with a life expectancy at birth of 86. And importantly, a decision was made to no longer make a distinction between males and females, because the arguments that there is an inherent biological difference in life expectancy are becoming less compelling as we see the gap between male life and female life expectancy in high-income countries, and particularly among the higher socioeconomic groups in high-income countries, getting narrower and narrower. Maybe this is a good point to stop and invite comments and questions.
That sounds good. Thank you very much, Theo. Anyone have any questions?
I'd just like to ask if there has been any public consultation for prioritization purposes in order to figure out how the people rate one condition over another to get priority in healthcare, other than, I think, the well-known Oregon consultations of some decades ago.
Okay, I understood that you're asking for whether we've had any public consultations on how to allocate resources.
Yes.
And I thought you were referring to severity of conditions one against another.
Yeah.
So let me start with that, because we did extensive empirical work on disability weights. You know, those magic numbers between 0 and 1 that determine the severity of one health state as opposed to another health state, and bounded between 0 being fully healthy and 1 fully unhealthy or dead. For GBD 2010, we conducted 5 country surveys, 4 face-to-face interviews in low-income countries in Peru, Bangladesh, Tanzania, and Indonesia, and a telephone interview survey in the US, and then had an open access internet survey where we changed the methods by which we derived these severity weights to what we thought is the simplest way of asking the question, and that's by asking people to make a pairwise comparison between 2 health states. And we devised a set of 220 mutually exclusive health states that would cover the range of disabling outcomes of all those diseases and injuries. And respondents at any time would get a random pair of those 2 health states with a brief lay description, and then the question posed to the respondent was, who of the 2 is the healthier? And by doing this many, many times over with all these random pairs, that allows us to parse the results of all these estimates across the spectrum between 0 and 1. So since then, we had an opportunity to latch on to an initiative in 4 European countries, and we worked together with the researchers there, provided more resources to buy more sample, and we've actually doubled the number of respondents from the GBD 2013 effort by adding in these 4 new European surveys, and have recalculated all the weights accordingly. So there's been extensive consultation, obviously not of a representative sample of the whole world. It'd be pretty hard to imagine how you would do that. But we're looking at expanding the evidence base of deriving these valuations. And so far, our conclusion across all these different settings where we have carried out these surveys is that when you specifically concentrate on health loss, that it looks like there's remarkable consistency in how people respond to these questions.
Okay, thanks.
Does that answer your query?
Yes.
That's yeah, very thorough answer. Hillary.
Okay, so you can't see me anymore because I've moved off to the side, but I did that so that you could hear me. So it looks like this kind of framework is going to have to draw a sharp line somewhere, and the character of my question is just about where exactly it draws it. So is it the case in the framework you used that, say, the death of a newborn infant at an age of one day after birth counts as 86 years of life lost, but a stillbirth doesn't count as anything bad at all. It's just about, I can see you're going to have to draw a line somewhere and anywhere's going to be awkward. I'm just curious about where people choose to draw it in this framework.
You're right. That's exactly what we do so far. So we don't include in our global burden of disease estimates stillbirths. And you could say, you're arguing that there's a very fine distinction between a baby that just doesn't make it to its first breath after delivery and a one who does. And so by making that sharp division, we say, the stillbirth doesn't count towards health loss, but the baby who catches maybe one breath and then dies accrues 86 lost years.
Right.
That obviously is not great, and it is particularly not great when you want to do economic evaluations of obstetric interventions, where you explicitly would want to be able to give a value to the loss of health due to a stillbirth, because it is exactly the same things that will prevent that stillbirth that will prevent the death of a newborn that does manage to catch a single breath. The difficulty that we have of dealing with stillbirths in the global burden of disease framework is that we make all our estimates by underlying causes. The literature on stillbirths is such that it tends to make a distinction between fresh stillbirths and macerated stillbirths. So ones that occurred quite a bit before delivery and the ones that occur during the process of delivery. But there is very little evidence to actually classify those stillbirths due to an underlying mechanism. Was it a congenital malformation? Was it an infection? Was it obstructed labor? So as that information is poorly kept, it's hard for us to incorporate it into our cause-driven schedule of the global burden of disease. And hence we've tended not to give it attention, but I do realize that that's not quite consistent with our aim of measuring health loss from all causes. There's been some debate about this, and Dean Jameson in 2006 suggested an alternative way where there is a slow creeping up of the value of a death in fetal life from when the fetus is viable until it is fully grown at term, and he extended that then also by suggesting that the value of a loss of life ought to go up until the kid is a couple of years old. And of course, there are really interesting issues that I would like some of you to tackle on what actually do people think about this. So I would suggest that this would be, and I've said this in previous meetings with philosophers and ethicists, this would be an excellent topic to do empirical work, and it'd be great if some of you would want to pick that up.
Okay, great, thanks. Toby?
Sure. Hi, Theo. It's Toby Ord here. I was at.
Hey, Toby.
I was at that meeting of the philosophers and economists, where I think all of the philosophers and economists thought that the current form of age weighting wasn't very good, which is the form you got rid of, but were more inclined towards a form like Jameson's one, which Dean assures me that his form is something like that is going to be in DCP3 when that comes out. And there's actually a meeting happening in Norway in June on that. Can you hear me, Theo?
Yeah, I only half heard what you said.
Okay.
I think you're saying that at the meeting that we had, there was support for something akin to what Dean Jameson has been suggesting, and that you'll have another meeting on this in June?
That's right, in Norway. So expect some results out of that. And I've been trying to push these people towards an empirical approach, as you said.
Yeah.
I
guess intuitively, I think some way of incorporating stillbirths into the overall scheme would be great. I think the more difficult thing is if you want to extend it into young children as well.
Yes.
So because I suspect that there may be quite a lot of differences in how people would view the loss of life in a newborn versus a 6 months old versus a 2-year-old versus a 5-year-old. So it'd be great to see empirical work on that, and I guess also empirical work in different cultural settings.
That's right. So I was curious to start a conversation on ways in which population particularly matters for the GBD. So the global burden of disease. One thing you could do is to ask what's happening to the proportion of DALYS being caused by the different illnesses and so forth. Population seems to be not so relevant to that question. Another question is what happens to the total global burden of disease, and if we introduce a new person into the world who has a very healthy life up to 85 years old and then dies, they produce one DALY, and so they increase the global burden of disease. And what to do about some of these questions depends on what the data is going to be used for. And I think that it's not necessarily all that difficult for you guys, because I don't know if you use it in any ways which are problematic. One thing you could do is just talk about the healthy life expectancy, which is equivalent to the basically to the DALYs per capita, and that doesn't seem too bad for what you're talking about, although it can be bad for other things. This is like the average view that we've been attacking today. But can you mention any ways in which your data is used by people where these questions about, should the DALYs go up with a larger population, and questions like that come out or are relevant?
Okay, well, a number of things there. The fact that the absolute burden increases when the population increases, that's fine. And we actually make a lot of use of that by distinguishing in our results the shift in the absolute numbers of DALYs as opposed to a shift in age standardized rates. Mm-hmm. So the absolute shift in DALYs is important for planning health services, because that gives you an indication of what the burden on health services is. Whereas if you're interested in epidemiological trends, then it's probably better to compare age standardized rates, where you take out the effect of population growth and population aging. So we deal with that all the time. And we do realize that there are difficulties in communicating that at times, but I think with the visualization tools where we allow people to examine all the results in different ways, I think will help convey those messages. Where it, I guess, becomes more difficult is when you think about economic evaluations of family planning interventions. So, because in principle, you can say that the net effect of using family planning is to prevent all these healthy life years that potentially could have arisen from that.
That makes sense. Do people think about using the global burden of disease to make a choice like that, or can you wash your hands of that problem?
Yeah, well, there are family planning organizations who are keen to use the DALYS in their decision making in terms of resource allocation, and that's where you run into these issues. How do you then quantify that in terms of a health outcome measure like the DALY? Now, I would argue that because we are explicitly in the business of measuring health loss, that just looking at a health loss indicator like the DALY is probably not the best way to evaluate family planning interventions, where the impact is far more on general welfare rather than on health loss.
Okay, thank you so much, Theo. I think we have to end it there because we have to make it to dinner on time. But we really appreciate the talk and you taking the time to Skype with us.
Yeah, no worries. And I look forward to future opportunities to interact.
Okay, let's thank Theo.